For decades, heart failure, particularly the most common type of heart failure today, which is heart failure with a preserved ejection fraction, was viewed as a disease that could not be meaningfully treated. In fact, we had no treatments up until recently for HFpEF. We knew that obesity was the root cause of heart failure with a preserved ejection fraction, but we did not have any approaches, nor did we have any clinical trials to specifically look at the so-called obesity phenotype of heart failure. So patients had very few options. Heart failure continues to limit quality and quantity of life every day for millions of patients. And then the GLP-1 receptor agonist trials offered some hope. Welcome again to Six Health, Conversations with Dr. Subodh Verma. This is the GLP-1 MasterClass. Clear conversations about what matters in cardiometabolic medicine from the experts for the patients, expert opinions, clinical impact, and patient impact. I'm delighted again to welcome Professor Darren McGuire. He did a wonderful job in our previous episode, and we continue our discussion on cardiovascular outcomes and the evolving science of GLP-1 therapies. And today we'll talk about GLP-1 therapies and heart failure. So welcome again, Darren, and thanks so much for joining us.
All right. Thank you, Subodh.
Well, Darren, the big problem of heart failure, right? Burgeoning impact throughout the world. The numbers are on the rise. Heart failure with a preserved ejection fraction is growing and really offers there are very few therapies that we have to improve quality of life and mortality in this population. So maybe for our viewers, could you just tell us more about heart failure with a preserved ejection fraction and why obesity is so important in this context?
Yeah, as you know, as we embarked on these trials of the GLP-1 receptor agonist, we were largely focused on atherosclerotic cardiovascular disease outcomes, but it's very clear that these patients with really high prevalence of overweight and obesity have a very high risk of getting heart failure. And to your point, as we've gone through this field over the last decade or even two now, I think a lot of non-cardiologists think about heart failure and they immediately think about a weak heart. But to your point, the prevalence of heart failure is almost 55, maybe even in some populations, 60% is heart failure with preserved ejection fraction. We've seen this flux of HFpEF, as we'll call it, track spot on with the increasing prevalence of overweight and obesity. It's a cardiometabolic phenotype. And so we were pleased, as you know, to begin to see signals from the cardiovascular outcomes trials of the GLP-1 receptor agonists. And those signals led the companies developing the drugs to actually focus on trials testing their efficacy in people to treat heart failure with preserved ejection fraction. And as we continue to move forward, hopefully we will continue that domain into preventing it to begin with.
That's wonderfully said. Thank you for that, Darren. I think one of the misconceptions and misunderstandings out there, particularly when we're talking to people, is what does heart failure actually mean, right? Oftentimes people feel, is my heart failing? Is my heart weak? But it's a much bigger syndrome. Could you tell our viewers more about the syndrome of heart failure, particularly as it relates to HFpEF and obesity?
Yeah, it's a great question. And throughout medicine, I've been deputy editor of circulation for 10 years. And in the editorial process, we've gotten more and more sensitive to person first and patient first language.
Yeah.
And the term heart failure is ominous. And so, we have clinics now in the States. I don't know what's going on in Canada. We have clinics now that are called heart function clinics and not heart failure clinics. And I like that. To say it's failing, okay. So when we as cardiologists talk about heart failure, it's simply the inadequate blood flow to the body from the heart. And it can be from a lot of different reasons. One is a weak heart, but also valvular heart disease, atrial fibrillation, and in the context we're discussing today, it's often left ventricular hypertrophy, a stiff heart that doesn't feel well with limited stroke volumes. And so at the end of the day, uh, the the crux is elevated left ventricular end diastolic pressure, right? So elevated EDP is where everybody gets their symptoms: shortness of breath, shortness of breath laying down, limited exercise capacity. It's all hemodynamic, and it almost doesn't matter in the patient symptom complex what's causing it. The symptoms are the same. So when we talk about the GLP-1 receptor agonist, we're focusing almost exclusively on HFpEF.
Now, I love how you've just sort of made this a patient-centric discussion, right? Because that was where I was heading next, and many of the clinical trials, and I had the good fortune of working on some of them with you and with Dr. Casaboro and others. Really asked a question from the patient's lens, and that is, quality of life with heart failure. So, you know, um, clinical trialists often focus on so-called hard endpoints of heart failure, hospitalization, and cardiovascular death. But for the patient in the trenches who's short of breath, who's actually struggling with heart failure, I'd like to hear what your thoughts are around, GLP-1 receptor agonists and how they improve their quality of life. Is that meaningful, and is that something that we should be taking seriously as a cardiovascular community?
Yes, absolutely meaningful, right? So we've labeled these trials often a feel and function trial, right? How does the patient feel and how are they able to function? It doesn't have to lead to a hospitalization or even an urgent visit for acute heart failure care. If a person is symptomatic on a daily basis at home, anything that we can do to make that day-to-day life better, well short of requiring a doctor visit or even a hospitalization. And so, as you mentioned, the trials that we've seen, really remarkable impact, favorable impact, are patient-reported symptom scores and how far they can walk. In this case of the trials, we do what's called a 6-minute walk test. How far can you walk in 6 minutes? And the GLP-1 agonists have improved that by 25 meters. And it may not seem like a huge amount, but that's, for some people, that's a 20%, 30% increase in their ability to function. And then, of course, what's most important is the patient-reported outcome scores. How are you feeling today?
And you're absolutely right. I think at Circulation, when you were the deputy editor, we wrote a lot about the so-called KCCQ, clinical summary score. And patients often look at me when I say, and it improves KCCQ, as if now I'm talking about something completely esoteric, which I understand. And really, as you've distilled that, down to improving the way they feel in terms of shortness of breath, improving their ability to walk more, improving social functioning. Those are such meaningful outcomes in heart failure that I think, are just as important as sometimes the harder endpoints.
Yeah, and I'll give a tip of my hat to the FDA in the U.S., who in the cardiovascular and kidney community, the FDA has begun accepting patient-reported outcomes as an indication for approval of a therapy, and it's led by the heart failure domain. And so even our regulators who are reviewing and approving drugs for use in humans are acknowledging that these symptom scores, however you want to measure them, we use the Kansas City cardiomyopathy questionnaire often, but whatever the symptom score, when we can objectively determine that people are feeling better, that's that can underpin a new drug approval. And so, as in the incretin modulating space, the GLP-1s and other broader therapies, is we're now looking at ideally, hopefully soon, FDA approval just based on the patients feeling better.
That's phenomenal, and I think for patients who are having or struggling with breathlessness and many of the other symptoms, this is critically important. Now, before we close, the bigger perspective of unanswered questions. Now, we talked a lot about heart failure with a preserved ejection fraction, uh, but there are people out there who are struggling with heart failure signs and symptoms and have a reduced ejection fraction, the other type of heart failure. What do we know about GLP-1 receptor agonists in that space, and what are the unanswered questions?
Yeah, we've had effectively damped harmonic oscillation in that field, led led early on by some of your really thoughtful colleagues in University of Toronto who know a lot more about myocardial mechanics and metabolism. We had a lot of optimism early on that these drugs would favorably affect the cardiometabolic milieu of the heart and improve heart failure with reduced ejection fraction. Then we took a couple of hits. We had two smallish trials, each of about 400 patients. The FIGHT and the LIVE trial that showed that at least liraglutide, a once daily injectable GLP-1, failed to improve heart failure outcomes in people with reduced ejection fraction. So we had to take a pause with our enthusiasm and take a step back. And I actually co-authored somewhat of a cautionary editorial
Mm.
that we published in circulation, that we just weren't sure what we were doing with GLP-1 receptor agonist and low EF, reduced ejection fraction heart failure. But then came the SELECT trial, and we get a lot of information from this 17,000 plus patient trial, where 25% entered the trial with heart failure, and half of those 25% had reduced ejection fraction. So we have a huge subset of a very large trial. And in the heart failure with reduced ejection fraction subset of SELECT, all of the cardiovascular benefits were observed. And so that's a trial with semaglutide once weekly injectable. And so it looks like at least semaglutide is at least safe, if not potentially beneficial in these patients. So we're not yet ready to say everybody with heart failure with reduced ejection fraction needs these drugs, but I think we can say we can safely use the long-acting once weekly injectables.
Well, that's wonderful. So there's a lot more to come, a lot more science that we need to evaluate and test. But I think it's safe to say that a medication from diabetes to obesity, from obesity to cardiovascular disease to atherosclerotic disease, really promising effects of this class of medications to improve signs and symptoms and patient outcomes in heart failure with preserved ejection fraction, with a lot of hope in patients with reduced ejection fraction. It really represents, the gift that keeps on giving. So it's been wonderful chatting with you, Darren. Thank you very much. And I look forward to welcoming you to our third and final episode with you in the next few weeks.